Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got a 100% on my NPTE, and this led me to found sptwithme.com, which is an NPTE prep platform. If you enjoy what you see and you're studying for the NPTE, check us out at sptwithme.com for our prep courses. Now, for what you're actually here for, let's talk about cranial nerve 3, the oculomotor nerve. This is an anterior to posterior view of the thalamus and the brainstem. Now I will say the oculomotor nerve, the path of this nerve is actually pretty simple. You can see that it comes out of the midbrain and travels in a ventral direction, so it's coming towards you. This is a posterior view of the thalamus and brainstem. You'll see that there's nothing evident of cranial nerve 3 being here because it starts in the midbrain and goes ventrally. You won't see anything on the backside because of that. With this lateral view, you can see cranial nerve 3 and its direction traveling outside the midbrain. Before we start to get into the pathway which the nerve takes, I think explaining its function will help out with understanding that part a little bit better. So there are actually two general functions of cranial nerve 3. The main thing that we normally think about is its somatic motor involvement with the extraocular eye movements. So let's go over that first. This nerve pretty much involves all the muscles of the eye aside from the superior oblique muscle and the lateral rectus muscles. So essentially it does all the movements aside from abducting the eye and rotating the eye medially. These two actions are not covered by this nerve. They're supplied by other cranial nerves, which happen to be number 2 and number 6. However, again, that's not part of this video. The other somatic motor involvement this nerve has is the activation of the levator palpebrae superior. This is the muscle that raises our upper eyelid. Sorry for showing such an intense photo, but it allows you to see where this muscle is actually located, which is just deep to the skin. Now let's get into the other function of cranial nerve 3. This is one that we normally don't immediately think of when we consider this nerve. And I think that's probably because as physical therapists, we just do not feel as comfortable with the eyes and what goes on within the eyes. But what you should understand is that even though, we're talking about the eye and the lens and pupil constrictors, these are still muscles. And as physical therapists, we should love muscles. Now, within this function, there are technically two functions. So cranial nerve 3 has involvement with the parasympathetic system. So think about rest and digest. Well, with the pupil constrictors, if you take a look at the image, you will see that there is a dilator muscle and a sphincter muscle. The sphincter muscle is circular, while the dilator muscle is straight up and down. Cranial nerve 3 innervates the sphincter pupillae muscle. When cranial nerve 3 is activated, it's because the parasympathetic system is on, and we want to contract, thus constrict the pupil. Now, if it helps, think about the opposite. With the sympathetic nervous system, if this is on, the pupil is going to dilate because we want as much light as we can possibly get into our eyes so that we can see better, so that if there's a bear chasing us, we have enough light for us to make good decisions about what to do in our environment. So the opposite must be true then when we are activating the parasympathetic nervous system. So something I want to touch on, and I'm not even sure if this is a question you might have, but it is something that I was confused on as a student, so I will touch on it. So if we are talking about constricting the pupil, for me when I was a student, I was thinking, well, if I'm contracting a muscle, and especially the sphincter muscle, how come my pupil is not getting larger? Why is it doing the opposite? Well, if you think about it, let's compare this muscle to any other muscle of our body. So let's say the biceps muscle. If I flex the biceps muscle, doesn't my muscle actually get bigger? The size of it increases, right? So the same thing happens with our sphincter muscle. We are going to contract, thus increase the size of the sphincter muscle, which ultimately is going to end up covering more of the opening of the pupil. And for this reason, the pupil gets smaller. It constricts. Okay, let's go on to the second function that this nerve has within the parasympathetic system. So take a look at the lens. Cranial nerve 3 has involvement with another muscle called the ciliary muscle. And this muscle's purpose is to adjust the shape of our lens within our eye to allow focusing on objects that appear at different distances. Cranial nerve 3 in particular causes the lens of our eyes to thicken. So if you take a look at the image that's on the screen, when the ciliary muscle is shorter, this means that the lens is thicker. When the ciliary muscle is longer, this is because the lens is flattening. If we thicken the lens, which is what this nerve induces, this allows us to focus better on nearby objects. So it helps with us seeing close objects. Let's go back to talking about the pathways. Again, I thought it was important for you to know the functions of what the oculomotor nerve does. That way you can see why there's going to be multiple routes and pathways that the nerve travels in. The picture that you see here is a cross section, a transverse cut of the midbrain. Again, this is where the nerve originates. Because there are two different functions, right? A somatic motor function and a parasympathetic motor function, it's going to make sense that there are going to be different location of where these two nerves start. The somatic nerves are going to be the ones that control the extraocular eye movements and the eyelid movement, and these begin at the oculomotor nerve nucleus, while the parasympathetic motor nerves, which have its role with respect to pupil constriction and lens thickening within the eye, these nerves are going to have its own origination, and this happens to be at the Ehringer-Westphal nucleus. Both begin in different places and they end in different places, but they are both still part of cranial nerve 3. This is an image that goes a little bit more into depth, specifically about the parasympathetic motor section of this nerve. Here you'll see that in our midbrain, our preganglionic nerve originates at the Ehringer-Westphal nucleus. Preganglionic because you will see that it will eventually synapse with another neuron called the postganglionic nerve. We're talking about the autonomic nervous system. The cell bodies inside the Ehringer-Westphal nucleus will then turn into an axon and eventually exit the midbrain, as we've seen in previous images. It'll then make its way to what's called the ciliary ganglion, and this is where that synapse occurs between the preganglionic and the postganglionic fibers. The postganglionic fibers will make their way to their respective sites, which in this case are the pupillary constrictors and the ciliary muscles of the eye. In this image, we do not see the route or pathway respective to the extraocular eye muscles, nor the eyelid muscle, but it is a way that you can at least see the pathway a little bit, even if it's just a part of it. So when you think about it, there seem to be 4 functions total of this nerve, which makes sense why you would have 4 different tests that you could do, one for each function. Now, one of the tests that you can do is called the H test. This is where you either move your pen or your finger in a manner to where your patient has to follow it with their eyes. You move in a pattern that makes the letter H so that you can pretty much hit all the corners and all angles of your eye movement range. This test, the H test, is really compiled with other nerves as well, so cranial 3, 4, and 6. However, if we were to just focus on the oculomotor nerve and the movements that you actually care about with respect to this nerve only, you would want to see the quality of elevation, depression, abduction, abduction, and torsion specifically in the movement caused by the inferior oblique muscle. Now, another test that you can do is with respect to the other function. It innervates our levator palpebrae superior, which is our eyelid muscle. So the way that you can test it is just by having your patient move their eyes open, right? Have their eyes open. If they are affected, you're going to see that one of their eyes or maybe both of their eyes are a little bit lower and they don't open as wide as you might expect. So far, we've addressed the somatic motor involvement. So now it's time to address the parasympathetic involvement. This is where the idea of a pen light comes in. So we know that whenever you shine a light into your eyes, your pupils are going to react by constricting. So to test this, what you have your patient do is cover one eye. You'll test each eye separately. And you're going to bring your pen light, with the light on obviously, from the side and then directly over the eye. You want to see its response. Hopefully, as expected, the pupil should get smaller. This is called the direct response, the side that you are testing. Now, on the side that you are not testing, even if you don't shine that light over that pupil or over that eye, it should also constrict. This is called the consensual response. Same idea with the other eye. You're going to test that eye individually, shine that light over that eye. Is it constricting? Yes. It's a working direct response. Uncover the other eye, the contralateral eye that you are not testing directly. Does it have constriction as well? Is the consensual response working? Lastly, we have the idea of convergence and accommodation. This is kind of actually a mix of both the somatic and parasympathetic motor involvement. So you're going to have your patient sitting, facing forward. They do not move their head at all. What you have them do is stare at your finger or either a pen, and you come in from a distance, but you slowly move it towards their nose. So you expect to see a few things from this. You expect to see that both eyes are converging and they're both moving medially at the same rate. So it's testing the medial rectus extraocular eye muscle. Now at the same time, you're also wanting to see that their pupils constrict more and more as the object comes closer. So understand that the farther away an object is, our expectation is that our pupil size will be larger, while the closer an object gets, the pupil size will be smaller. Now, one last thing within convergence and accommodation is that you want to see how close a patient is able to see an object clearly. So you start with that person sitting still, staring at you, you're moving your finger towards them at a distance, move them slowly so they can concentrate, and you essentially ask them to tell you when they start to see double vision or whenever the finger or pen starts to get blurry. A healthy adult will be able to see your finger from 6 inches away from their eyes. If it starts to get blurry or you start to see double vision from a distance that's farther than 6 inches, so let's say 7 inches from your eyes, this might suggest that there's something wrong with their lens and the ability of their lens to accommodate for this change in distance of the image and object. Now, as we age, of course, this starts to get a little bit harder. So there is some leeway in that. However, 6 inches is a general guideline. So in this particular assessment, we are assessing the functionality of the lens. So as you can see, wrapping up all these tests, there are a lot, but it's a matter of just hitting all the bases of what Cranial Nerve 3 does. Hopefully this makes studying for Cranial Nerve 3 a little bit easier. If you're studying for the NPTE, check out our prep courses at sptwithme.com. Check out these references for more information.